Acknowledge our university and community supporters, the University of Iowa's International Programs and the University of Iowa's Honors Program, and the Stanley UI Foundation Support Organization for their financial support. And we thank today's special financial sponsors, Mike Margolin and Jim and Pat Fgrave. It is my pleasure now to introduce Dr. Christopher Squire, who will introduce our speaker. Thanks.
Thank you, Dave. It's a very great pleasure for me to introduce both a friend and a colleague from dentistry, Dr. Pete Damiano. He's director of the UI Public Policy Center. He's a professor in preventive and community dentistry in the College of Dentistry. He received both his bachelor's and his DDS from the University of Iowa. He then went to the University of California for his MPH before coming back to join the faculty of the College of Dentistry. He also has been a Robert Wood Johnson Dental Health Services Research Scholar, and his work as director of UI Public Policy Center is well known in studies of the access to and the quality of health services. In doing that, he's published more than 200 articles. He's been a PI, principal investigator, on 75 research studies. His work has focused on healthcare reform, on coverage of healthcare, health disparities, healthcare for the uninsured. These are all incredibly timely topics. As you know, both nationally and locally in the state, we are facing big issues here. Pete is intimately involved in these locally, as you probably all know. So I'm sure we're very eager to hear what his insights are into these major issues. Pete?
Yeah, that's okay.
You can plug that.
Yes, I'll plug that one. Yes. Good afternoon, everyone. It's a real honor and a privilege to be here. And thank you, Dave and Christopher and Ed, for the invitation. Iowa City Foreign Relations Council to me is one of those organizations and one of those entities that really makes Iowa City special. And this is one of those things that brings people together from the university and the community in a very thoughtful way. And that's what we try to do at the Public Policy Center. We're not an advocacy type of center. We do background research to try to inform policymakers on a variety of different issues, whether it's crime and justice policy, environmental policy, social and education policy, or what we'll be talking about today in terms of healthcare. And so that's where I'm coming from. I'm not trying to say things are good, bad, indifferent, whatever, but just engage in an intellectual conversation that I know this group is, particularly well positioned for that. So you have to start talking a little bit about the U.S. healthcare delivery system and then transition to an overview of a couple of different systems and talk about why, what they sort of represent. But one of the reasons that we do this, or that I'm interested in this, and I don't claim to be an international healthcare expert at all. My work is more on the U.S., doing what's called health services research, where we look at access to care, quality of care, cost of care kind of issues, as Christopher alluded to. But when you do that, you can't help but hear, well, what about Canada? What about England? What about this? How can we learn from those? So this is something that has been of academic interest to me. I'm going to be lecturing to the medical students in a couple of weeks on this. So that's really where I'm coming from, not as an expert. Many of you have probably received healthcare in other countries, have different kinds of experiences, which, if you want to bring that up to the Q&A is something that's really important and interesting. And then I really want to focus on, we get so hung up in a sense on the healthcare delivery system side of things that at times, whether we're talking about healthcare reform in the United States or international comparison, we forget that it's all about health. The only reason we have a healthcare delivery system is to try to make us healthier. It's not about how many widgets we can do or how much, hospital revenue we can generate or things like that. And that's the part of what I want to try to bring into this discussion about international health comparisons. So when you think about whether it's in the United States or elsewhere, there's three big things, and these are the things that we study in health services research: cost, quality, or outcomes, and access. in terms of cost in the United States, so this is your first quiz question. How much do we spend on health care in the United States? So how many of you would say A? Okay. How many B? How many C? Okay. How many D? Okay. Some of you may remember back to third grade when you're not sure, always pick C, right? So we spend about $3 trillion a year on health care in the United States. And obviously that's not equally distributed, whether it's across systems or across people, right? There's a real tail, as we would say, in statistical analytic perspective in terms of where that money goes. And when we talk about who's spending that, we talk about those as healthcare purchasers. So the United States is somewhat unique when we think about that relative to many other countries in the world, because we think of our employers that we have some sort of this employer-based health insurance system, which is really something that we can talk about later, but it's much more happenstance than was intentional. Happened during World War II when there was a wage and price freeze on. Companies started offering it as a benefit to try to attract and retain employees, and then we started allowing businesses to write it off their taxes, and so that's what grew that portion. But that's been on the decline for the last 15 years or so. And that's one of the reasons we've had an increase in the number of uninsured, one of the reasons that the Affordable Care Act was able to get passed and to fill some of those gaps. Then obviously government programs, which right now is actually, in terms of what we spend on, is a larger portion than on the private side. So what are the big government programs that you're aware of? Medicare, VA, right? Medicaid, Children's Health Insurance Program, all the public health programs, right? All of those are government programs, either from a financing and or delivery system side. And one of the things that it's really important when you're thinking about, again, whether it's an international or US, is separating the finance from the delivery system. Because too often we meld those things together in our discussion, and especially with the international stuff. Well, that's socialized medicine. Well, what does that mean? And then they'll lump, as if England and Canada are the same, and they're very, very different in terms of the financing and the delivery. And so when you're really trying to learn something from these things and what does it mean to us, you have to be able to separate the finance from the delivery system, private, public, what does it mean, how efficient is it, all of those things. And the government financing programs are actually much, much more efficient than the private. As it turns out, but then consumers. And that's another thing that's been changing of late, is that as employer costs have been going up, they've been pushing more of their costs onto their employees. And so whether it's through healthcare savings accounts or other kinds of cost-sharing arrangements, it's much more costly for consumers than it used to be in many cases. And so where do we spend our money? It's a little dark, but about a third of it is on hospital costs, about 20% on physician costs, and then the distribution from there. One of the big areas that people are really concerned right now is pharmacy costs, because those have been ratcheting up very quickly as a proportion of healthcare costs, and something that it's difficult right now for us to get our arms around, in part because, for example, Medicare, which would be one of the largest purchasers with Medicare Part D, the pharmaceutical part that went in the late 90s, there is a clause in there that says that the government cannot negotiate drug prices with the drug companies, which you could argue doesn't make a whole lot of sense, but drug stocks are in many people's portfolios and all these other kinds of things as well. But that's something that you're hearing people right now on both sides of the aisle, including President Trump, talking about, that we should do something about that. But when I was talking about that uneven distribution of healthcare spending, what this is saying, that for 1% of the population, they use about 27% of all the healthcare costs in the United States. So we know those are the really sick folks, some from an acute situation, some from a traumatic situation, some from a chronic healthcare disease perspective. And 10% uses almost 70% of all the healthcare costs. And this becomes really important when you start thinking about, again, system level kinds of things, and when you hear people talking about how are we going to hold down healthcare costs. Well, one of the ways is to look at what are we doing to keep that 10% healthier and reduce the fact that they're spending that much, and or trying to prevent some of the chronic illnesses of the people who fall into that. So that's what's really important when you start thinking about it from a system perspective. In terms of access to care, from a policy perspective, we often fall back to insurance. And that's what, especially with the Affordable Care Act, people have been focusing so much on the insurance expansion, which is important. but not on the delivery system side, or again, what we're really trying to do with it. But this is a definition from a while back in 1981 that I still think is the best definition of access from a broad perspective. And it's the set of dimensions describing the fit between the patient and the healthcare delivery system. So if you think about what are the barriers to someone receiving healthcare, financing is one of those. But anyone know what's the most important reason someone seeks healthcare at all? Is it because you have insurance? No. What's the most important reason you use it? Well, it's perceived need, right? That could be pain, that could be some sort of illness, that could be trauma, whatever, but it's the perceived need. Then you start getting into the other things like, do you have money so that you're going to, or insurance, to seek it? Or is that a barrier that holds you back? Or I've got insurance, but I can't find any doctors that will take my insurance. Or it's after hours and I have no way to see my physician, so I'm going to go to the emergency room instead. Or all of those kinds of things that get involved with that idea of fit. That I think is really important when you think about access. You get into language, culture, all of those other kinds of things that also affect a person's fit. And if they don't feel comfortable, they're not, maybe they'll go in the first time, but they won't necessarily go back. And we're talking about chronic disease management, that's critical, right? Because you're really talking about behavior change at that point. And if a person isn't comfortable and isn't going back, that's never going to happen. So we still have about 28 million people who are uninsured in the United States, about 10%. But that's down from 50 million before the Affordable Care Act came into place. So it hasn't solved the problem, but it has sort of taken on that next chunk, if you will. We do a much better job with kids, in part because of the Children's Health Insurance Program. So in Iowa, the CHIP program covers children of the working poor up to 300% of poverty. And then with the Affordable Care Act, it goes up to 400% if you want to purchase the subsidized insurance through the health insurance exchanges. On the adult side, Medicaid, especially in the states that didn't do the Medicaid expansion, can still be very, very low in terms of the percent poverty and whether you're eligible. And if you're under 100% poverty level, you're not even eligible to purchase the subsidized private insurance on the exchanges because of the way the law was written. So there still are things, when we talk about the repeal, replace, repair, there are a lot of repairs that everyone knows could be done, should be done from the day it was passed. But it's the political will, and can we really sit down across the table and do some things, and we'll see how that happens. One other thing that's important to understand: there's 25 million people who are underinsured. Those are people who have insurance, but their insurance isn't going to cover them in the event of some sort of a catastrophic problem. And unfortunately, with that group, it often they don't know that they're underinsured until they have some sort of problem. Many of these people think that their insurance is pretty good, go in, whatever, get cancer, get into a car accident, and all of a sudden it's not there. So that's why in the United States is somewhat unique in that we have many healthcare-related foreclosures and defaults that people in other countries just don't get. So this is before the Affordable Care Act, and what this is basically showing is that 80% of the uninsured were working people and their families. So these weren't people who weren't trying. I would talk about it as if they're working in the wrong job. And so you could have two people doing the exact same thing, working at two companies right next to each other. One gets health care benefits, the other one doesn't. And those people aren't going to be able to afford it because 2/3 of them are making $50,000 a year or less. And average family insurance policy in the United States right now is about $16,500 a year. So if you're making $50,000 a year or less, you don't have that kind of disposable income. So you'll hear some people saying, well, there's all these people that don't want it. Our research has shown that's not true. That there's all these people that could afford it and aren't buying it. Again, are there a few? Yes. When we're talking about broad population-based numbers, absolutely not. So what we've chosen to do in the United States, which is again very different than in other countries, is that we've taken a very incremental approach to insurance coverage. We've never truly said that having financial access to care is a right in the United States, that most other countries sort of start with that premise and then think about how they might want to build a systematic approach around that. We've taken this incremental approach. So we had the tax incentive added during the 40s, as I mentioned, during World War II. Then the biggest gaps that were after that were seniors. That's where Medicare came in 1965, and Medicaid was sort of slid in along with it, primarily seen as a program for poor moms and kids. Anyone know where the money in Medicaid actually goes? Nursing homes is a huge part of it, which was never expected when Medicaid started. Dialysis is another one, which was added later, but it's at people with disabilities. So between people with disabilities and people long-term care facilities, basically 2/3 to 3/4 of all the money in Medicaid goes to that. And moms and kids are actually pretty cheap. So again, when we're thinking about how are we going to save money, this idea that we're going to cull all these moms and kids off of a program and save a whole bunch of money, I mean, let alone that would be the right thing to do. But if you think about it just strictly from how are we going to save money, it doesn't make a lot of sense. And so we're trying to, at least from a systematic perspective, think about, some are, where the money is and where we can actually improve quality and reduce costs. But it's a very difficult thing to do. Then the Children's Health Insurance came, and then the Affordable Care Act, which was basically trying to fit the next gaps, which were single adults primarily, who were not Medicaid eligible. You had to be both poor and what's called categorically eligible, so again, mostly moms and kids to be eligible for Medicaid. And so they could be working, low income, not getting his benefit. They had no option for that. People with pre-existing condition and the whole change in the individual insurance market. So if you got sick and you had bought a policy, you could get dropped. Your cost could go up so much that you couldn't afford it. So those were some of the changes that were implemented with the ACA in that individual market. So it gets to this idea, does the United States have a healthcare delivery system? No. So President Bush's Secretary of Health and Human Services described it as we have a group of healthcare sectors. We don't have a healthcare system, and I think that's a good way to think about it. The VA is a system, the Indian Health Service is a system, et cetera, but they don't connect together very well, right? And the long-term care system, this idea, well, we could spend some money and keep people out of nursing homes because we could provide more home health support or something. Well, but who's going to do it, and who's going to pay for it, and who's going to save if we do? And these things aren't connected very well. And you could argue whether that's good or bad, but that leads to a lot of the pushing on the balloon thing, and you do this and you have an unintended consequence over here, or how do we actually deal with some of the more challenging problems because they're not connected in a systematic way. And I think when you think about how do we make it better, what can we learn from other countries, it's important to keep that in mind. So I'm just going to talk about a few countries, and in general, you can divide among the industrialized countries in particular between those with a private delivery system and a public insurance program and those that have both public delivery and public insurance. So most countries other than the United States, as many of you are aware, have a public financing of the healthcare, which is different, again, than we have here. But the delivery systems vary a lot. And so that's really important because we're not going to privatize our delivery system overnight. We have been making incremental movements towards public financing. We're not there yet either. But when you think about, well, what can we learn from those? Again, that distinction between financing and delivery is really important. So in Canada, they have a public insurance program at the provincial level. It's not, again, a federal program. Each province has their own. And if you look at those characteristics at the bottom, those are things that in general we would probably all agree a healthcare delivery system should have, right? It's sort of mom and apple pie, should be universal, accessible, comprehensive, portable. Many familiar with HIPAA? The privacy, we think of it as a privacy issue, right? Anyone know what the other P in HIPAA is? Portability. That was designed to allow people to port their insurance with them. And they realized, well, if we're going to do that, then we're going to have some sort of data tracking so that we'd know how to do that. And then all of a sudden, oh, now we're collecting all this personal health information in one place. How do we keep it protected? And so it's, you start getting into these things become a lot more challenging. Again, these are the different criteria you're talking about. And basically, in Canada, it covers virtually everyone outside of just a few folks. So it is a universal financing system. And this was something that was one of the big changes with the Affordable Care Act, was the moving toward some sort of essential health benefits that's been identified. So there's sort of been this impression that if you have private and employer-based insurance, that it was better than public insurance or better than buying something. But why do employers in the United States offer health insurance? Right. It's recruitment and retention of employees, right? It has nothing to do with, you might argue, well, we keep them healthy and all that kind of stuff, but most of, going to the doctor is not going to keep employees healthy in the sense of your workforce. But it's recruitment and retention. It's not about how good the insurance is. So the employer is going to put in as much money as they feel like they have to be able to recruit and retain employees, right? And so that wasn't necessarily comprehensive. Well, with the introduction of the ACA, there was a minimum essential benefits package, which did make some things more expensive. And you could argue at what point it should be comprehensive, but you started getting mental health parity and a number of other things. And so which of these are we going to say isn't important? Which one do you not have to cover? And they basically decided everything in Canada was important. The Netherlands, the Holland system is actually kind of interesting because it's one of the few you don't hear a lot about, but in some ways is closer to a model that I think we could move towards if we wanted to. Everyone receives a basic insurance package there, and then there's additional levels that either an employer can give you or you can purchase depending on what they want to do with that. And so this level 1 is basically public catastrophic. Everybody gets this public catastrophic insurance. So everybody's got this basic amount. Then the second level depends on whether you get it through your employer, which might be a little bit more generous, or whether if you don't get it through your employer, that there's still a public component. And then the supplementary to the private, which would be things that would be beyond what they would consider in their minimum essential health benefits package. So this is something that at least everyone would have something. And I think that where you draw the line is a legitimate policy discussion that we may all not agree on, and that's where you should have your policy discussions, but around something specific, not what I call small r religious view of something being good or bad, but this service is worth paying for or not or requiring, and that's what this sort of does. It sets that up. In England, they have a National Health Service, and Christopher and others could speak to this a lot better than I, but it's where basically the government runs both the financing and the delivery system. So the vast majority of the healthcare sites, so hospitals, clinics, are government owned. Most of the healthcare providers are government employees. And so again, when you hear this socialized medicine, well, what do you mean by that? Financing, delivery, whatever. And this is something that's really important when we're thinking about this system level change. Huge system there, and in general, most of the surveys have shown that people really like it. Not that they haven't wanted changes at times or wanted more control over what they get at a local level, because it is organized at a federal and then a distributed system, and at times there's been some concern that there is more control at the federal and things that you can imagine. And then there's these strategic health authorities that were set up to try to give the people in the local areas more say in what's going on. The bottom line is nobody has this perfect, right? Every country is struggling with cost in their own way, struggling with how to deliver the services the best, but there still are things we can obviously learn from others. There is a growing movement towards some privatization in England and some private hospitals and some companies from the United States that have been going over there and doing some things. But for the most part, again, it's still a public system that's sort of a pride of people from what I have heard. Japan is really interesting, and we had a graduate student went over there and did an internship there a couple of years ago. It's similar to Canada in that they have public health insurance and mainly private providers with universal coverage, but there's only modest cost sharing on the part of patients. So that's something you hear, that we should be putting more of the costs on the consumers here and operating more as a free market entity and all of those kinds of things. But they have still fee-for-service payment for the most part, but they've got relatively low healthcare costs there, even though they've got an aging population older than the United States. But their system's very different. The families are involved in the care delivery and other things that we don't have here as much. Physician numbers are relatively low, but their hospital lengths of stay are really long. And so, which again goes counter to some of the things that we think here. So what does this mean when we think about healthcare costs and what it across these different countries? So this is the healthcare spending per capita, and as you all know, the United States, we spend way more on a per capita cost than every other country in the world. The light blue over there is for the industrialized European countries as a whole. This is showing both as a per capita as a percentage of GDP. The percent of GDP that we spend roughly 17, 18% of our gross domestic product on healthcare. Is that a bad thing? Right? Pays for my job. Right? Pays for all these physicians and nurses and everybody else. So did we decide that's what we think is the right thing to do? No, that's that lack of systematic, right. We just do it, right? And this is what it ends up at. But it is, it's a big part of the economy. But what it does, there's something economists call opportunity cost, where every dollar we're putting into healthcare, we can't put into the environment or the military defense or whatever it might be, right? And so from an international perspective, if you're a corporation that's competing in an international business, your costs are going to be much higher than theirs are, which drives up the cost of your products, which makes you less competitive. So that's one of the things where this becomes really important. We also spend here, that white bar in the United States, that's a private spending. Again, depending on how you define private, right? If you're paying in taxes, you could argue that's private. If it's coming out of an employee's wages, that's money that could have come out, for their benefits, something that could have been out. But that's where it seems very different in the United States. And this is what's called a mortality amenable to healthcare. So there are many things that happen that the healthcare delivery system isn't going to do anything about. These are the things that the healthcare delivery system, if it was better designed, could be more effective at. And we're still, the white bar there was 97, 98. The blue is 2006, 2007, the most current data on this question. And we're still worse than most countries, even taking into account those things. So not just spending or infant mortality or health outcomes or those things which you normally hear about. So why are our costs higher? So the disease burden is higher in the United States than in comparable countries, and this has to do with a measure called disability adjusted life years. So we do have more disease here. Though the disease burden is decreasing pretty much across many countries, the difference here is still greater. So we're making improvements, in other words, but not as fast as we really need to, especially from an international perspective. Cancer and circulatory diseases are the leading cause of disease in the United States. What do those diseases tell you? What are they? Why do we have them? Lifestyle, right? Behavior, lifestyle issues. Is that something the healthcare delivery system can deal with? Not well. Right. Public health, yes. But the healthcare delivery system that we focus on, not as much, right? Mental health problems and circulatory disease are the leading cause of disease burden. And so if you really look at who are those high-cost utilizers, many of those folks are what we call dual diagnosis, have a physical chronic illness as well as a mental health problem. And when we're talking about, well, we're going to reduce emergency department use or this or that, when you're dealing with people who have mental health issues, diabetes, other kinds of things going on in their life, very difficult to actually address that. Hospital discharges, well, maybe it's because we're hospitalizing way more than everybody else, but not really. We're less than the OECD median in terms of hospital discharges per 1,000. Is it because the average number of physician visits, that we have way more physician visits? Well, that's not it either. So we're actually relatively low on physician visits relative to these other countries. So is it because we have too many physicians and there's something called target income theory that the physicians are going to be shooting for, this is what I want to earn, and they're going to be doing tests and do all these kinds of things, and it's because we have too many physicians? Well, that's not it either. So we don't have nearly as many physicians per 1,000 as many other places. Cervical cancer screening rates, is it because we don't do a very good job? Well, no, actually we do. With clinical preventive things compared to many others, we actually, 85% of women screen for cervical cancer screenings. So we actually do pretty well on that. But then you look at what do we do when somebody does get sick, and other than Germany, we're lopping off a whole bunch of legs because of people with diabetes. So you could argue that's because of the delivery system and we have surgeons who like to cut, or you could argue that it's because we have people with really severe diabetes that have been unmanaged for lots of different behavioral issues and a lot of other things that have gotten to that point. So that's going to be obviously drive up costs. You look at hospital spending per discharge, and yeah, our cost per discharge, even though the number are lower, our costs are way high. Some have talked about imaging as being a big deal and something that we can, you give people, we're going to give you $1,000 for your MRI and you shop around to get it. And there have been some studies that have shown, yeah, that can work. And for certain isolated things, that can. But again, if you go back to that 10% of the population that's using 70% of all the healthcare costs, consumer shopping ain't going to do it. But our costs for imaging is much higher. Physician incomes in the United States are much higher. And we've got a big differential between not only what specialists make and primary care docs make, we have a big shift in the proportion of our physicians who are specialists versus primary care physicians. Most countries have a much higher proportion of their physicians that are primary care. They do less interventions, less procedures, going to hold down costs in that way, medically manage things. Where in the United States, you tweak your knee, you want to see an orthopedist. That's just sort of our culture. So then you think about what can we learn from other places? Well, we can learn some of these things, but are people here going to do it, right? It might make perfect sense somewhere else, but if it doesn't fit our culture, it doesn't really matter. So what do we get out of this? So number one, healthcare spending. We're last in life expectancy, infant mortality. You've probably seen these things before. Makes it look like our healthcare delivery system's terrible, right? Is that true? Yeah, not really. So this has to do with satisfaction about availability, and the very satisfied, actually in the United States, we have some that are more satisfied and some that are less, but access, you probably heard people, come across the border from Canada. That's probably overplayed a little bit, but they do have a lot of queues because they don't have as many healthcare providers and you do have to wait. In the United States, we're not going to wait, right? That's not, again, our culture. And this gets back to this idea of health versus healthcare, which is really important in all of this not to lose. So it's not just about how many things we can do or get or receive. It's that our determinants of our health, most of them are outside the direct delivery of care in the healthcare delivery system. So when we're talking about healthcare, international health comparisons, it's really important to keep that in mind. And so when you think about what are the things that determine whether any of us are healthy or not, what are those things? What we eat, diet, activity, exercise, sure. Sleep, stress. Sorry? Social support, absolutely. Environment, right? Our genetics, right? You know people that have smoked till they're 90 and other people who die at 28. Guns, yeah, violence, trauma. So when you think about it's been broken down into this simplistic sense, and I'm not going to stand behind these exact percentages, but the idea about half of our health status is related to lifestyle, about 20% environment, about 20% genetics, and only about 10% of our health is related to the healthcare delivery system. So again, in this international comparison that we're talking about, we don't want to get too hung up on just the healthcare delivery system side and where we can learn from other countries about this. So where do we put our money? Well, very systematic approach, right? You look where your problem is and you take your resources and apply those effectively. Well, maybe not. Because this just happens, right? We have a delivery system which is big business, and I don't mean that necessarily in a bad sense, but even a good sense. That's what we're doing. Insurance is important, and insurance is so you can get more stuff. Well, but it may or may not actually make you healthier. So these are some of the things that people have talked about as the determinants of health. And sometimes they're called the social determinants. I tend to take off that social because it makes it sound like they're soft and fuzzy and not really that important. But it's like, no, these are the things that are really important. You know, whether you have housing, whether you have a good job, whether you have nutrition, you're living in a food desert, all of those kinds of things are much, much more important on a day-to-day basis on whether we're healthy than anything that has to do with the healthcare delivery system. It's a part, but all of these things are what's really important. Early childhood, we know that 0 to 5 time is critically important for the long-term success of a child. And so focusing more on these things, which we don't have a public health system in the United States either, and we spend much less on public health than we do on others. So this is somebody's attempt to look at the ratio of social to health spending. And again, this is where we really do fall down relative to other countries and directly affects our healthcare status. And so what this is interpreted as social service versus healthcare spending in the United States, for every dollar we spend on healthcare, we spend about 90 cents on social services. In the OECD countries, the European industrialized countries, for every dollar they spend $2 on social services. So if you really want to think about bang for your buck in terms of health status, this is something that we could learn from. Culturally, are we ready to accept this? That's a different issue. Clearly, right now, federal administration probably would not be very supportive of this. But it is something that still needs to be kept in the dialogue and in the policy discussion. And so obesity prevalence in the United States, you know, much higher than everywhere else. Again, you go back to what those determinants of health are. Smoking, that's actually something that we've done pretty well compared to many others, thanks to people like Christopher and others who have been working on that issue for a long time. But there's a real disparity on who smokes in the United States and how that affects their health status and all of the other determinants. It tends to be clustered in the folks who those determinants of health aren't good anyways. And then you're throwing smoking into that. So that's generally not a good thing. So for those of you who are interested in international health comparison, the Commonwealth Fund is a really good source for information in an unbiased way, both about U.S. healthcare reform and discussions, but also from an international perspective. And they've got this tool where you can compare across on a variety of different things. So just to summarize, we know the United States spends much more than others, with the health benefits of all of that spending, I'll say unclear, but probably not the return on investment that we would like in terms of health status. But I would say be very careful about simple comparisons about the United States spends too much and, you know, everybody dies. Well, like those mortality rates, if you think of what goes into mortality, again, 90% is not the healthcare delivery system. That doesn't mean we can't do better, and that a slide that I showed that has to do with the healthcare system related mortality, that absolutely. But just that simple comparison, you know, when you hear that, at least try to think a little bit further down through that. What are we doing on the non-healthcare delivery system side? What's the financing like? What's the delivery system side? And there are important lessons that we can learn beyond that, as we were talking about the social service side. And keep in mind what's important is health, not health care. Public health is part what determines that, and the determinants of health. So how can we incorporate those things more effectively? Trying to do that on the delivery system side through what are called accountable care organizations. Some of you might be familiar with the ACOs, Unity Point, the University Alliance, a number of these, and they're trying to focus more on what they're thinking of as population health and taking care of people before they land in the emergency room or get readmitted. But that's not really what our individual healthcare system is good at. And so applaud the effort, but I think in the long run, it's going to take much more on the public health side to be able to build an infrastructure that can help with that. And then what are those cultural aspects or things that, yeah, this would work here, that's a great idea for them, but we would never accept that. Or how might we sort of move in that direction over time? So with that, happy to entertain questions, have a discussion. This is, yes.
Social services. Please spell out what is meant by this and how it could affect health.
When I think of that issue of social services, what really comes to mind is what are the ways that we can impact the behavior change side of this to try to reduce chronic illnesses in particular. And that, to me, is the holy grail of healthcare costs and healthcare delivery system change. You know, we all know we should eat better, right? And we all sort of cycle, and sometimes we do, and sometimes that cheeseburger looks really good. And, you know, or exercise. You know, there's days, I go to the gym 4 times a week, and the next time, I just don't really feel like it. And there's also a part of this that I think, do we really want anybody to be able to affect us at the level that they're going to be able to do that, which is something in the United States, culturally, we don't like, right? And that's with the Affordable Care Act, all the opposition, in my opinion, was really based on the fact that people felt like they had to do something. So even though the individual mandate and that idea that you had to have insurance really only affected about 6% of the population, everybody felt like, by God, you know, that I'm being told I have to do something that many people just don't like that. And when you'd break down the ACA and say, okay, well, you know, should large businesses have to cover their employees? Oh, yeah. Should we get rid of pre-existing conditions? You bet. You know, on and on and on. Everybody says, yes, yes, yes. Do you like the Affordable Care Act? Oh, no, it's terrible. And, you know, we have, again, that sort of cultural thing. But from the social service side, it's really how do we help people who are ready for behavior change to eat better, control their diabetes, exercise more, and do it in a way that fits them and fits their lifestyle, or the mental health side. We know we have not only a lack of a mental health system, if you will, we don't have enough mental health providers. And how you find the right fit for someone with mental health issues is very challenging. It's not like just because you've got a psychiatrist or psychologist somewhere, that's going to work. And so it gets really complex. But those are the social service sides of things that are where I think we could, if we wanted to as a country, could improve on, but it would take more public financing.
Okay, another big one, Pete. Please explain myths and truths about rationing.
Yes, rationing. So as many of you may recall, when the ACA was being debated, there was this talk that it was going to be rationing care and we were going to pull the plug on grandma. And Senator Grassley, while he didn't say it, he didn't dispute it when he was asked. Anyone know where that came from? No, it actually came from a Republican legislator in Florida, House member, who was trying to get into the bill so that physicians could get paid for end-of-life counseling. And, you know, because right now they were doing it and they weren't getting paid for it, and probably had some physicians talking to, you know, this is something we should get paid for, and in Florida, do a lot of it. And so doesn't seem like at that level, at that policy, that's a very unreasonable thing, right? Doing end-of-life counseling is really important. And, you know, paying them $1.50 or whatever is not going to be, you know, but then that got twisted by the opponents to say that now we're going to be rationing care. And it also assumes we don't ration right now, which of course we do. We ration in lots of different ways, either intentionally or unintentionally. It could be from a financial perspective, it could be from a geographic perspective, but if you're in rural Iowa, you're going to have to travel a long way to get mental health care, for example, and that's, you know, a form of rationing. The transportation thing is actually also really interesting because and I just did it, think of rural being the transportation problem. Well, many people in rural areas, they're used to driving, right? They drive everywhere. So they don't actually have the same transportation issue that someone who's on the east side of Des Moines might have trying to get to a provider downtown or on the west side. And so it becomes much more complicated than that too.
Now, we had to get to this one. What do you think about Iowa's Medicaid privatization?
So at the Public Policy Center, we do a lot of evaluation research for the Department of Human Services, the Iowa Medicaid Enterprise. And again, I'm not going to come and say something is good or bad. I can talk to you about it at a policy level and certain things that are going on. We were talking about this earlier. One of the things that's very positive about our working relationship with the Iowa Medicaid Enterprise is that they do want information about what works and what doesn't. And so I was on the phone with them for an hour this morning. This was specifically talking about the dental portion of the adult portion of Medicaid. And based on our research last year, again, not us advocating or banging on the table, but showing them that there are a lot of people that couldn't get care because of the structure, blah, 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 they changed the structure. Now, did they change it the right way? Again, we're not the policymakers. We're evaluating and we're developing the evaluation plan with them and with federal CMS to do that, to try to figure out what works and what doesn't. On the medical side, we know that one of the biggest changes, not just moving to managed care, but taking those very vulnerable people, those people with disabilities, the people with long-term care, people that have had the same case manager, care coordinator for 15, 20 years, and all of a sudden shifting them to this new system and causing that kind of change can cause a lot of disruption. And it may not be for most people. You know, your average person Medicaid may be sicker than the general population, but not necessarily that much worse. But there are a lot of folks who are the sickest of the sick. And when you think about healthcare costs, what we've done in the United States, we've taken the most expensive people and put them in the government programs, into Medicare and Medicaid, for example, and we've left the lesser expensive young, healthy adults with employers and in the private side of things. So yes, our government programs are going to be expensive by definition. So what we're working on is trying to see what works, what doesn't, and share that information back.
This is really a follow-up to that. Are you, the Public Policy Center, currently monitoring or gathering data on this privatization?
And we are for parts of it. So there is a group out of Arizona, which is called an EQRO, who's a quality monitoring company, who they contracted with to do the global quality assessment in coordination with Center for Medicare and Medicaid Services. We are, though, we've got 2 reports coming out next week looking at the consumer perspective on those changes, both from the Medicaid expansion component of that and then from about adults and kids and those in what's called the SSI program or Supplemental Security Income Program, which is the disability part, and looking at where that is coming from.
Okay, so this is more a statement, but I think you'll have views on it, Pete. A good first step would perhaps be to go to Medicare for all ages from birth to 18.
Right. So when you think about where do we go from here, as I showed, we have taken purposely this incremental approach in the United States. So where do we go next? And clearly in the last few months, we've shown that going backwards is not going to come easy, meaning taking 22 million people off of the insured rolls, and many who were opposing the ACA knew that at the beginning. And one of the reasons they were opposed and wanted to stop it because they knew once you give somebody something, it's harder to take it away. And that's sort of where we're at. But if you wanted to continue down that path, a Medicare for all would be an option. Now, one of the things people forget about Medicare was never meant to be comprehensive insurance. When it was started in 1965, it was a catastrophic program. Did not cover dialysis, did not cover routine services. Over time, those have been gradually getting incorporated into it to fill gaps. So then it's a question, if we were to do that, again, how we're going to finance it. Providers would probably actually love it, because instead of dealing with all these different systems and everybody telling them that you've got these rules to follow or this formulary that you can prescribe from, everybody would be in the same thing. But culturally, are we there? We'll see.
Okay, to return to the international dimension, would you have any comments on how decision-making regarding things like medically necessary treatments, tests, etc., are handled in other countries, such as England?
I can't speak to that specifically, but there are definitely issues of rationing everywhere, again, in different ways. In Canada, they've got issues, as I understand it, where they don't have enough providers in many places, and they're going to queue. You're going to be in a queue. You want a hip replacement, you're not necessarily going to get it next week like you would demand here. You also have geographic issues where you got most of the population is along the U.S. border, and then you've got a lot of really, really rural areas. In terms of end of life or specific rationing, I'm not that familiar with, so I'd prefer not to go down that.
Okay, and again, are some of the costs that we include as healthcare expenses hidden in other countries under other categories?
Again, I can't say I can speak to that. However, all of these data are suspect, right? I mean, when you're thinking about, they haven't been collected consistently in the same way from these different places. So that is absolutely something that should be taken with a grain of salt as you're looking at this. It's broad generalities. Do the exact numbers, the exact proportions, all those things, are they accurate? Probably not, again, because we know they're not being collected in the same way consistently. So what gets counted in healthcare costs will absolutely vary from country to country in lots of different ways.
And this is the last card, and it says, fascinating presentation. Will these slides become available for reference?
Yes. No. Yes. Short answer is yes. I'd be happy to provide them in whatever way works with this group and this organization to share in whatever way you want. I do want to, again, thank you very much for the invitation to be here. This is a great organization. And before I leave, Linda Levy has left some books from her husband, Sam. Some of you probably knew Sam from the College of Public Health and Department of Health Management, or the precursor to the Department of Health Management and Policy now, who was there for many, many years and a mentor and friend to many of us. And she's brought a number of his books on health policy and international health comparison that you're all welcome to take a look at, take any of them that you'd like. But again, thank you very much. Really appreciate the opportunity to be here.
Thank you, Peter. I also want to thank our sponsors, the University of Iowa's International Programs, the University of Iowa's Honors Program, the Stanley UI Foundation Support Organization for their generous support, and we thank today's special financial sponsors, Mike Margolin and Jim and Pat Epfgrave. And we thank City Channel 4 for making our programs available to viewing audiences. And Pete, as a token of our appreciation, we present you with the coveted Iowa City Foreign Relations Council mug. We are adjourned.